Hello, we're back and we're going to take a look at more things about healthcare data. We'll look at reliability, validity, all these other different types of things. And again, here we are with more things about data in healthcare. Things we'll specifically look at today are comparing and contrasting reliability and validity of data. Just because something is out there doesn't mean that it's reliable or valid. Example, if you follow baseball stats, if somebody has 10 at bats and got seven hits out of 10 at bats, is he a Hall of Fame player? I'll let you determine your own conclusions on that, but based on the sample size, the data may not be reliable or valid. We'll look at different categories of healthcare data, and then we'll connect the healthcare data flow to data types and uses. And then we'll look at some of the more commonly used, I should say, sources of external data. A big thing with healthcare data is validity and reliability. Validity is it accurate? It's the ability of data to measure the attribute that it's intended to measure. So does it really measure what it's intended to measure? So in terms of these things, let's go back to our baseball analogy. The data is accurate, but is it really measuring the attribute that it's intended to measure? Is it really telling us if somebody gets 7 hits out of 10 at bats, whether they're a Hall of Fame player or not? Probably not. So we could say it's not valid. Reliability is a different concept. This is basically saying, can we repeat this type of result over time? In the case of a batting average, yes, we can. We take the number of at-bats somebody has in the denominator, we get the number of hits they have. In the numerator, we have a ratio known as the batting average. There are different types of validity. In other words, one that you talked about a little bit with the baseball analogy is, does the metric measure the quantity it was intended to measure, right? And we assess this sometimes by asking different opinions, right? So if we want to know if somebody's going into heart failure, we might ask a cardiologist, does ejection fraction actually measure whether somebody's going into heart failure or not, right? If we don't have the face validity, we really don't have too much to work with. Then we have the content validity. In other words, is it enough? Are the components of the metric necessary and sufficient to measure the quantity, right? And we get into this when we talk about patient satisfaction surveys. In other words, if we have questions in there that are not relevant or they're poorly worded, those types of things. And then we have the construct validity. And what we're looking at here is, does the measurement tool capture what we're looking for? Right. So if you're asking if students are satisfied with LCC library services, and you're asking about all these other things, you really don't have construct validity. Criterion validity asks the question, does the metric agree with an accepted gold standard for measuring the same quantity, right? So in other words, if you're looking at lab tests like a CRP measures inflammation. Could be inflammation due from an MI, inflammatory bowel disease, all these other different types of things. So does it meet the criterion of, say, measuring whether somebody's having inflammatory bowel disease or not? Maybe it does, maybe it doesn't. Inter-rater reliability is measuring the reproducibility or the consistency of the metric between two different raters. And we do this a lot in research when we're having two medical record reviewers, and we'll give, say, a 5% sample of the population that they're working to study and see if the two medical record reviewers get the same results. That's what we call inter-rater reliability. Intra-rater reliability is talking about the reproducibility of the metric with the same medical record reviewer, but doing the review at different times. And there are different statistics that we can use to measure reliability, the kappa statistic, Cronenberg box, all these other different types of things that we'll get more into later in the course. The different types of healthcare data. There's internal data, things that come from the electronic health record, claims and billing, patient satisfaction surveys, and then there's the external data. These are things like the cancer registries, the MortalLink database that we have for all deaths in the state of California. We have Medicare claims data. All these things are external. They're external to the individual healthcare organization, as opposed to the internal data that, say, you would get at Oregon Medical Group or at Kaiser Permanente Northwest region. We look at diagnostic data. We can't talk about diagnostic data without talking about ICD-10-CM. ICD-10-CM is the coding set that applies alphanumeric strings of text to diagnostic statements. ICD was designed as a disease tracking system, but it's used in the United States as a payment driver, as it determines MSDRGs, HCCs for reimbursement under prospective payment systems and risk-adjusted data. How does this work in terms of using diagnostic data? Well, the Centers for Medicare and Medicaid Services pays for inpatient services that are given to Medicare patients via an inpatient prospective payment system. So in other words, they're saying this is how much a hospital will get paid based on what this patient has. So what they do is they group different diseases into diagnosis-related groups, or DRGs, as we say, and these diagnosis and procedure codes are combined with other demographic data to group patients and determine payment. And then we split DRGs further into MDCs and all these things, and then we update the new codes and the DRGs starting in October for the following year. And here's an example of it. We have I-50.4. This is combined systolic and diastolic heart failure. And then we also code end-stage heart failure if applicable, I-50.84. Look over here about all the different types of ways that this can be split and further divided. And again, with procedure codes, we see the same thing. As we know from ICD-10 PCS, we're interested in the procedure. So if you think about the components of a procedure, we want to know what type of procedure was it? In this case, 0, meaning the medical and surgical section. It was done on the urinary system body part. And it was a destruction. In other words, we physically eradicated part of the body system. And then we would select what body part, right, left kidney, right kidney, pelvis, right or left, ureter, so on, and how we got there. what the approach was, what the device and the qualifier were. Likewise with CPT codes, we're looking at different levels of office visits, as you can see here. And of course, pharmacy data, we have all different types of things that are out there in terms of classifications of medications. Come back for the next video lecture on Chapter 2, where we'll be talking about more administrative data, revenue codes, and so on, and things that are outside the realm of clinical data. That's all I have for you right now. We'll see you online. Bye now.